All right, we are ready to go. Welcome everyone to the event. I'm happy to see all of you here, and we will turn it over to Candace, I believe, who will start the event.
All right.
Candace, if you're not there, Marty, do you want to go ahead?
Sure. I'm Marnie Delaney. I'm chair of Democrats Abroad's Global Disability Caucus. And today I'm co-moderating for this event, which we have co-sponsored along with the Medicare Portability Task Force and the Senior Caucus. Our shared perspective is that all of us as individuals need or we will need to make a variety of decisions which significantly impact our short and long-term financial and health situations. They're important for people with disabilities, seniors and pre-seniors, and actually also critical for younger people who are planning for their retirements, and frankly, for everyone, because none of us can say with certainty what our circumstances will be as we make our way through the years. I know I've had surprises. So the plan in this session is to describe what Medicare is, how it is funded, and to whom it is available, the nature of the coverage, and what it does and doesn't include. Our intent is to provide a lot of information, but not to provide advice or opinions on particular situations. We will, however, be sharing a compendium of some of the freely available resources you can access to get additional information which you may need to make those decisions. We'll also share an update. This is going to be interesting, I think, for you, an update on the work currently being done by the Medicare Portability Task Force with Heather, and it's very impressive. So to get us started, I have the pleasure of introducing Tony Kamens. Tony is a journalist and native of New York City who now lives in Paris, France. After covering a variety of subjects, including healthcare, politics in New York and the US, oh wow, that had healthcare politics in New York and the US, she now concentrates on covering Medicare and senior citizen issues. To this end, she publishes a Substack newsletter called the Medicare Reporter, which serves as a guide to the Medicare maze and updates readers about Medicare news and policy changes. So I'll turn it over now to you, Tony.
Hi, everybody. Good morning, good afternoon, wherever you are. As Marnie said, I'm a journalist, and among other things, I now work with Democrats Abroad from Paris, and I'm here to explain some basics about Medicare. Medicare, as you probably all know, if you've ever had any contact with it, is far more complicated than it needs to be. Has a lot of arcane language, although that's improved somewhat in the last few years, but it still can be way too confusing. And this is important for people who get Medicare benefits, who may manage Medicare benefits for a family member, who are thinking about, their retirement, et cetera. It's an important issue. And with that, let's have the first slide. So what is Medicare? Medicare is the federal health insurance program for people over 65 and certain other younger people with some specific disabilities, including end-stage renal disease. That's it in a nutshell. And now let's get on to some of the more complicated things. One thing that a lot of people get confused is Medicare and Medicaid. They are not the same things. Medicare is for older people and has nothing to do with income. Medicaid is for people below a certain income level and is administered. It's a federal program administered by each state individually. So each state has different requirements, whereas Medicare's requirements are federal. Next slide. Now, if you've had any experience at all with Medicare, you know that there are different parts to it. Each part signifies a different piece of the insurance puzzle and covers a different group of medical services. Medicare Part A is your hospital insurance. And this covers you when you're actually in the hospital, not if you go to a doctor in the hospital, but when you're actually admitted overnight into the hospital. And it covers your room and any medical services, not unnecessary medical services, but the basic medical services within the hospital. Medicare Part B is, I'm sorry, let me just backtrack a bit. Medicare Part A also covers you in a skilled nursing facility. And it's important to remember that that is not the same thing as a nursing home. Medicare Part B is your medical insurance. It covers your doctors or other healthcare providers when the service is performed in the doctor's office or a hospital outpatient facility. Now, that is essentially because these days, with hospitals having taken over many individual doctors' practices and many doctors practicing within the umbrella of the hospital, there are hospital outpatient facilities, and this is under the purview of Medicare Part B. It does cover some medical supplies, but it's very limited, and some preventive services, but generally this is not insurance for preventive care. Medicare Part C, which is now known as Medicare Advantage, I will get to later in the presentation. Medicare Part D is your prescription drug coverage, and it's entirely separate from Parts A and Parts B. Medicare Part D is private insurance that helps cover the cost of prescription drugs, and as well as many vaccinations and shots, which is a fairly recent development. Next slide, please. How is Medicare paid for? This is always a good question. Medicare is funded through general revenue into the United States, through payroll taxes that you pay when you get paid and your employer contributes to, and the premiums that you pay for your benefits. Together, this money funds the two Medicare trust funds, the Hospital Insurance Trust Fund and the Supplementary Medical Insurance Trust Fund. Next slide. Now, when you get paid, you will notice on your pay stub that there is a line that says F Federal Med/EE. That is the withholding tax that employees pay into the medical system. Now, employers also pay a portion on your behalf, but that does not get deducted from your pay. Social Security taxes are listed as old age survivor and disability insurance. Medicare taxes from your salary help to fund Medicare Part A only, the hospitalization portion. You only pay for Medicare Part B once you start receiving those benefits at or after the age of 65 through your monthly premiums. Next slide. The Part A premium is again taken out of your paycheck, and most people don't pay an additional monthly premium for Part A once they start receiving their Medicare benefits. Medicare, you may not qualify for Part A if you didn't work a required amount over the time of your career. And some people who make a higher income will pay an additional cost. Next line, please. Now, if you haven't worked enough to qualify for a no premium Part A, you can buy it. And in 2023, the maximum cost is $506 per month. That's the maximum cost. Next slide. Part B premium, your medical insurance, carries a standard monthly Part B premium of $164.90 in 2023. Now, if you have a higher income, you may be asked to pay more than that standard, and that's going to be determined by the Social Security Administration and is based on a previous tax return. So, for example, if you sell a house in 1 year and derive, after the capital gains deduction, derive significant income from that, you're gonna pay for that year, for the year that you sell the house, you will be assessed probably a higher premium for Part B, but that's temporary. Next, please. Now, how and when to enroll in Medicare? This is really simple. You go to the Social Security Administration website, create an account, and then on the home page, there is a Medicare drop-down menu, and you just follow the process to sign up. They'll ask you a few questions, and it's really pretty simple. Now, you can start your Medicare enrollment beginning the 3rd month prior to the month that you turn 65 until 3 months following your 65th birthday. This is known as your initial enrollment period, and it's very important that you remember this initial enrollment period because it has an impact down the line. Sign up for Medicare even if you know you won't be using your benefits right away, because if you don't, you may be subject to penalties. Next slide. How does Medicare work? Well, it's really pretty simple. It's administered by the federal government, and it covers your hospital and medical expenses at any doctor, healthcare provider, hospital, or facility that accepts Medicare, which is most places in the United States. The reason being is that most hospitals take some sort of federal money for one thing or another, and therefore they have to accept Medicare. Most doctors in the United States accept Medicare. This can vary a little bit. Sometimes in large cities, there are doctors who serve a largely affluent population that may not take Medicare, but overall, most doctors do accept Medicare. You don't have to choose a primary doctor. You can see any doctor you want who accepts Medicare and who's accepting new patients. You don't need a referral to go to a specialist. Now, let me go back to what I was talking about signing up for Medicare as soon as you're eligible. If you don't, you may face a late enrollment penalty. Next line, please. Now, you're going to say to yourself, well, I'm going to be working past 65 where I have coverage on a spouse's work health insurance. That's fine. You don't lose anything by signing up. You can defer your Part B benefits if you fall into a few different categories, as I mentioned, if you're still working or if you've got coverage through a spouse's or other insurance. As long as you have insurance, you can defer your Part B benefits. You don't have to start paying the premium, but it's important to sign up as soon as you're eligible. If you don't, and you don't fall into one of the categories, you will be assessed a late enrollment penalty, which is permanent. And depending on how many years you go without enrolling, if you're eligible, that penalty can be pretty hefty and lasts until your entire life. Next slide, please. Now, Medicare Part D has been a confusing issue ever since it was adopted under the Bush administration. It helps pay for your prescription drugs. It does not pay for everything, but it does help defray some of the costs. In addition, some states have drug programs for seniors that can pay some or all of the costs that Part D does not cover. It's also important to remember that Part D is private insurance, and therefore you're going to pay a premium, a separate premium for that Part D to the insurance company that issues your particular plan. And those companies are the insurance companies you all know: United Health, Aetna, Blue Cross. They all have different plans, they all have different costs, and they all have different formularies. A formulary is a list of drugs that the company will pay for, and that's broken into tiers or levels depending on the determination of the pharmacy benefit managers at the insurance company. Typically, generic drugs that are frequently used, like Lipitor, are on your lowest tier, and you'll pay a very low premium or a very low cost for that. And they can go up, but it's determined by the formulary. And when choosing a Part D plan, it's important that you look at the company's formulary to make sure your drugs are on it, what tier they are, before you make a decision. Each plan has a monthly premium, which you pay directly to the insurance company. And they can impose other costs, deductibles, ancillary costs, and that varies from plan to plan. And it's also important that you investigate what those are before you sign up for a plan. And again, as with Part B, if you don't have coverage, you're assessed a penalty. And now we come to Medicare Advantage. Medicare Advantage is formerly known as Medicare Part C. It's private insurance. It's entirely private, and it replaces Medicare for those Medicare beneficiaries that elect to use it. Next line. With Medicare Advantage, you pay your premium directly to the insurance company. You're issued an ID card that you use at the doctor instead of your standard red, white, and blue Medicare card. And as with any other private insurance, you're confined to a network of providers and hospitals within your geographic area, and you may not be covered at all if you go out of network. Most Medicare Advantage plans include a Part D coverage, but not all of them. So it's important to investigate that as well. Now, as for coverage outside the United States, some Medicare Advantage plans include emergency coverage outside the United States for a limited period of time. And it's important to remember that this is for travel emergencies only. It does not apply to expats. Medicare Advantage is actually funded by Medicare. Medicare pays each private insurance company a fixed amount per year for each Medicare eligible person they sign up. And after your initial enrollment, the sicker the Medicare beneficiary is, the higher the amount Medicare pays to that insurance company. Medicare supplementary insurance, also known as Medigap, is another confusing issue. It is supplemental Medicare insurance sold by private insurance companies, and it's meant to cover some or all of the costs that Medicare Part B does not cover. Now, it's important to remember when talking about the 80% that Medicare Part B does cover, that is 80% of the Medicare approved amount, not 80% of what your doctor ordinarily charges. If your doctor charges, for example, $500 for an annual physical, Medicare is not going to pay that doctor $500 for your annual physical, even if you live in an expensive place like Los Angeles or New York City. There is a contracted rate between the doctor and Medicare, and that's what the doctor is required to accept. And Medicare Part B picks up 80% of that. You're responsible for the other 20%, which may not be a lot of money. The supplement insurance is intended to cover all or part of that 20%. Medicare supplement plans are identified by a letter of the alphabet, A through G, and every Part A, every Plan A offered by any insurance company has to be identical to any Plan A offered by any other medical insurance company. However, they do not have to be the same price, and the availability of Medicare supplement insurance varies from state to state. So one state may offer plans A, C, and E. Another may offer all of them. Some may offer only one or two. It entirely varies by state, and that has to do with your state insurance regulators. As I said, monthly premiums vary, but every Medigap plan must have the same benefits as every other Medigap plan in that same category. Now, here again, some of these Medigap plans include foreign coverage, but only for a limited time out of the country, only for emergency care. And again, this is not for expats. Next, please. Now, Medicare for expats. The obvious and most important thing to remember is that Medicare cannot be used outside of the United States. There are some minimal exceptions that apply only to the border areas between the United States and Canada and the United States and Mexico. But to all intents and purposes, you can't use Medicare outside the 50 states. Now, if you're moving abroad, you can, and you know you're probably not going to go back to the United States, you don't have to pay for Medicare Part B anymore. But if you're unsure of what your future is, and who among us at our ages isn't, you can maintain your Medicare coverage if you continue to pay the monthly Part B premium. Some of us do, some of us don't. It's entirely a personal decision. But if something changes and you end up having to go back to the United States, either temporarily or permanently, and you have not continued to pay the Part B premium, you will be subject to a late enrollment penalty if you want to restart your Part B coverage. Next slide. If you live abroad, when you first qualify for Medicare, you've got to sign up by requesting enrollment forms from the Foreign Benefits Unit of the U.S. Embassy or Consulate in the country where you currently live. A list of these is available on the Social Security website. Now, many people have had the experience, particularly since the pandemic, of trying to get in touch with the federal benefits units and having absolutely no luck. If this is the case, the first thing you should do is send the local equivalent of a certified letter with return receipt to that same office. Many people have reported that that has proven successful when trying to get them through email or telephone hasn't succeeded. But I can tell you that these units, along with the Social Security Administration, are understaffed and underfunded. That was supposed to get better with last year's budget appropriations, but according to the latest information, they don't expect to see any improvement in this until at least 2024. Now, Medicare versus Social Security. One thing has nothing to do with the other if you live abroad. You can't use Medicare while living abroad, but you will still be able to receive your monthly Social Security payment. These payments can be deposited directly into your foreign bank account in local currency once a month, or you can continue to have them deposited into your US bank account if you still maintain one. If you live abroad when you become eligible for Social Security, there again, you have to contact the foreign benefits units at the embassy, and with the same caveat as I mentioned for every other federal benefit. Next, please. So that is it in a nutshell. I know you're going to have questions. Many of you will also have questions about your personal situation. Unfortunately, that runs the gamut from nothing to everything. And but we have plenty of resources for you to consult, online services and other services, so you can at least attempt to get the answers you're looking for without going very nuts.
Thank you so much. I'm going to interject and insert myself here to make an introduction of our global chair, Candace Karaston, who has a few comments to make. Go, Candace.
Well, thank you, Marnie. And yeah, Tony, thank you so much for that really, really comprehensive overview of really the ins and outs of Medicare. I'm sure that's echoed by many of the attendees on today's call. That was incredibly helpful. And just seconding your comment, I'm sure I'm calling you from a Pennsylvania voter based out of Munich, Germany. And I'm sure we're coming from different walks of life, different ages, different countries that we're living in. But this is so important to all of us. And I especially think that, as you mentioned, younger people also need to hear that message as it affects us all who are living abroad and working abroad. I wanted to just say a few words too here following Tony's presentation and before we dive into the next section about the work of Democrats abroad. I see it. Do I have an echo?
Yes.
Mm-hmm. Yes.
Could you two please mute? Hopefully it's better now. No.
We can take it. It's not
okay.
unbearable.
It's not unbearable. Great. I'll keep it short. I wanted to talk about 3 pillars of Democrats Abroad's work and our core mission as an organization. And the first is it both informing you and assisting you vote from abroad. So if you haven't already, there are tons of important state races coming up this year, state and local races. So please head to votefromabroad.org. As you saw in Tony's presentation, and I saw some questions coming up in the chat. A lot of this is regulated at the state level, right? So the decisions that are being made in your states matter, not just on healthcare policy, but education, environmental protection, the list goes on. So please get your ballot. And let's not forget to, I'm sure you've seen the headlines, Republicans are out to get Medicare and Social Security. As a party, I can tell you that Democrats are fighting for it. They're fighting to expand it. And they're also supporting, again, the work that we're doing here. So I will let Heather and some others in our team cover that down the road. Secondly, educating Americans abroad, such as yourself. And again, a shout out to Tony for that wonderful presentation. And last but not least, advocating for issues that impact us as a unique constituency who are living overseas. In the past 2 years, we have been able to launch a Medicare Affordability Task Force. We've also launched a Global Disability Caucus, a Global Seniors Caucus, which I'm very thankful to all of those involved in those projects and all of you for joining us today to learn more about them. It really is important that we come together as a constituency and make our voices heard in Washington. And I hope that you find that Democrats Abroad is the best channel to do that through. I know that I do, and I will toss it over to one of our leaders, Betsy Attore, chair of our Global Seniors Caucus, to take it from here. Thank you so much for being here today. Looking forward to your continued engagement in support of Democrats Abroad. And with that, Betsy, over to you.
Thanks very much, Candace, for your words of wisdom. Thank you. And now it's my pleasure to introduce our next two speakers, Heather Stone, Chair of the Medicare Portability Task Force, and Philippe Blumenthal, the CEO of the Government Savings Institute. Just to tell you a little bit about each one of them. Heather is a member of DA Israel. She became a licensed attorney in New Jersey in 1988 and practiced municipal bond law in New Jersey from 1988 to 1990. She moved to Israel for academic work in urban planning. She passed the Israeli bar in 1993 and practiced law with a few of the largest law firms in Israel, working in the high-tech sector on investments, international mergers and acquisitions, and internal investigations of publicly traded companies for over 20 years. In 2017, she became visually impaired following brain surgery. She volunteers for Democrats Abroad, currently as Deputy International Counsel Global, Chair of the Medicare Portability Task Force, a founding member of the Global Disability Caucus, and Vice Chair of DA Israel. In addition, she serves on the boards of various nonprofit organizations in Israel and was the past chair of Democrats Abroad Israel. Heather is a mom of 2 grown teens and 2 dogs, including 1 guide dog and 1 support dog. She continues to learn to navigate the world differently. Philippe Blumenthal is a serial entrepreneur, having founded several successful startups. He is currently focused on the Governmental Savings Institute, a Georgia not-for-profit, whose goal is to find ways to help governments save money while retaining or increasing the level of service the government provides. The International Medicare Pilot, which he started as a labor of love for his parents, is one of several important efforts. Other efforts include the teaching of self-defense for girls in high school settings in an effort to reduce the assault rates for women and the utilization of state financing benefits for carbon sequestration. Philip earned a BA from Brown University and an MBA from INSEAD. Okay, Heather and Philip, you'll speak for 15 minutes each. Thanks very much. It's over to you.
Okay, thanks so much, Betsy. Thank you. I want to say thank you very much to Candace for joining us and for her words to help motivate everyone to participate in voting in this year. So I do encourage everyone to request their ballots. Philip and I are going to speak together on this this presentation. And we're going to talk about the Medicare Portability Task Force, what we've been doing, and some of the more salient points about some of the studies that have been conducted and what we can learn from the data. So, ready, Philip?
Ready. I just also want to
Oh.
say thank you to Candace, thank you to Heather, thank you to everybody who organized the call, thank you to the people on the call, thank you for the people who also filled out a questionnaire, the survey that we did of Democrats abroad. You have the most organized international political organization anywhere in the world, with all of your members, over 150,000, ready to be able to work together. And it's an incredible force, which you've been able to harness, and hopefully we'll be able to harness it for the good of all Americans living overseas. So thank you, all of you, for all the extra effort that you all put in for showing up on a Sunday morning of a long weekend, wherever in the world you all are.
Okay, so this presentation, we're going to do a very brief review of Medicare because I think you've all heard Tony. And then we're going to identify the issues for overseas Americans because that's why we're all gathered here. And what are the challenges that are facing Medicare? And then go dive into an overview on the progress of the Medicare Portability Task Force. Next slide. So to repeat what Tony said, Medicare is the federal health insurance program for people who are 65 years and older. It does cover certain younger people with disabilities and for people with end-stage renal disease. Next slide. Parts A and B, which Tony covered quite comprehensively. Part A is your hospital insurance, and it covers your inpatient hospital stays, care at a skilled nursing facility, hospice care, as well as some kinds of home health care. And then there's Part B, which is your medical insurance for seeing doctors, outpatient care, medical supplies, and even some preventative services. These are the two basic forms that together would give you your kind of basic coverage that in many parts of the world is your basic health care, comparable to basic health care in many parts of the world. Next slide. So we're not going to repeat all the things that Tony gave you about the different parts of the other parts of Medicare, Part D, and the drug coverage and Medicare Advantage and so forth. But just to identify what are these issues for Americans who are overseas. So as Tony highlighted, Americans are not able to access Medicare benefits when they're overseas. It's only available to people who are in the United States. So Americans pay for Part B premiums regardless of whether they are overseas. And we highlighted this and we explained that there's a penalty if you don't enroll in Part B and then you go back, or if you stop paying Part B and then go back to the United States. So everyone needs to take into consideration their own unique circumstances in order to determine whether or not they should be paying for Part B. And if they do, they should, or if they stop paying Part B, they should understand what the consequences will be. Paying Part B premiums, those Part B premiums are deducted from your Social Security benefits, or they are directly billed to you when you're overseas. Now, DA members, much like the surveys that are done of overseas voters, constitute about reflect the same kinds of percentages in terms of the age groups So we did a study that Philippe's group, the Government Savings Institute, conducted of Democrats Abroad members. And we found that our members are also just like overseas voters, 20% or more 65 or older, and 27.5% are 60 plus. FEAP also has voters overseas who are 20% of their respondents are also 65 plus. So we're consistent with the voting population. So that's a good thing to know, that DA is just like the rest of the voter population. Philip, do you want to talk a little bit about the survey that we conducted and
Sure.
The responses that we got and the results?
Sure, I'd like to first sort of say the goal, sort of when I started this project, and really started to team up with Heather, and Heather said, well, we need to form a task force to do this. Where we had gotten was, the question is, could you make Medicare available for Americans living overseas? And if so, what would be the benefits to the US government for doing so? And so the first question is sort of, what could be the potential cost savings? Here I went to Israel and in Germany and in Mexico, and I got some notion of the fact that between 65 and statistical death, men it's 77, women it's 83, the average cost is about a little over $300,000 in the US, and it's less than half that elsewhere in the world. And that all of it, then I said, well, could you do this? Could one do this for about 2/3 of the cost to be sure that there's, enough something in it so that the countries that you'd send these seniors to would be willing to take them, and said, let's use a 2/3 of US cost as a basis. And I got positive responses both from German insurers, Mexico insurers, and in Israel from the Ministry of Health. That meant that we had $100,000 per beneficiary over lifetime savings potential if you did this. Then I had one survey which I conducted, and I said, how many people would take you up on this? And at the time, we came up with a number between 2 to 4 million, which would dictate a pilot of about 150,000 people, which would be the midpoint, which would be 3 million, and doing 5% of the midpoint. And I said, we have to do this over 10 to 15 countries. And I did this sort of with the advice of people on the Ways and Means Committee, the Appropriations Committee, CMS, CMMI, which is the Center for Medicare and Medicaid, and the Center for Medicare and Medicaid Innovation. And we sort of came up with the fact that this is about the right number that you'd need to be able to do this. For the government, and you always have to think about what does the government need for this, and how does it help the government, and how does it help the citizens, mainly us? So for the government, there's a cost savings. So now you could point to if this program were successful, right? If the pilot is a success and they expanded the program, you'd get to somewhere between 100,000 times 2 to 4 million is $200 to $400 billion of savings, which is already enough to attract the attention of the Appropriations Committee. Second of all, you have an issue that in the United States, you have between about 15 million additional Americans turning 65. In America, we have a shortage of about 300,000 doctors, about 700,000 nurses, 300 and 400,000 radiologists, hospital beds, et cetera. The whole medical infrastructure is this huge additional use that's coming up, and we're not set up for it in the state. So this helps solve the Medicare infrastructure, the medical infrastructure problem in the United States. It doesn't solve it entirely, but it helps. Thirdly, and most importantly for us, is that it reunites our families. Many of us on the call are Americans living abroad permanently. We would like to have our families be able to live with us, our seniors, that, you know, grandparents and grandchildren can be together. This is an incredibly important thing, and this would help allow this to happen. And I'll get to the results that we had in the survey. First generation Americans, I don't know if there are any on the call, who are losing their English. This happens a lot if you happen to come from the Asian countries, which is why the Asian caucus is very interested in this. It happens a lot in some of the European countries, but if you lose your second language, namely English or senility, you need someone who can give a caregiver and caretaker in local language. And so this can really only best be done, you know, locally. And this has been, we've had a lot of responses about this. It helps veterans. I don't know how many veterans we also have on the call, in the sense that if you happen to live right next to a US base or a hospital overseas, no problem, you'll be very well treated. If you don't, this is a much easier way for veterans to be able to deal with the coverage, especially as they become heavy users and unfortunately get sick overseas. It also helps bring back sort of best practices to the United States. Now, all of this is really important because it influences how the government is going to be able to want to do this. We may want it as Americans overseas. We need to be sure that the politicians understand that this is also in the best interest of the entire United States, not just in a small fraction of its citizens. And for this, the money-saving issue is incredibly important, as is the medical infrastructure. So having done all of this and having had Senators Murray and Blunt really help push things forward and get things into appropriation bills in FY21 and in FY22, one signed by President Trump, the other by President Biden, making sure that you had both sides and both parties very interested in this, because this is the best way to get this across the finish line. These things are very long projects. They take years, and you have to be prepared to be able to work with both parties while you do it. That said, then I came to Heather and I said, Heather, we really need to do a model that shows cost savings. And this is where Heather said, great, I have Democrats abroad and we can run the survey. And we worked together and we defined a survey which had almost 80 questions in it. We sent it out to all the Democrats abroad. The people who had approved this were not only within Democrats abroad, but we had on the Ways and Means staff, we had congressional offices look at this, we had CMMI look at this, we had appropriators, we had the Senate look at this. We had an awful lot of input into this survey. We had almost 4,700 responses, 60% of them were seniors. Most important, were to be able to show that the demographic was the same as the US demographic. This was true both in terms of disease prevalence and in terms of wealth. In other words, that you weren't sitting there saying, because you live abroad, you're rich, which was what a lot of people were afraid of in Washington on the Ways and Means Committee. And when they came to them, I said, look, here's the data. No, we look exactly the same. They said, okay, wonderful. Now we can consider this. The other thing that we saw that was important was that 36% of the non-seniors said that they had family, parents, or grandparents would want to join them if they would be able to deal with the issue of health insurance was one of the major things stopping this. Of those, 2/3 had serious long-term diseases. Now, this is incredibly important because it means that you're getting a lot of the expensive cases to leave the United States. Some of these expensive things are things like Alzheimer's, where the costs are going to spiral and will be much, much larger than what's being predicted in the markets, especially after I've had a chance to talk with the folks at CMS, the Center for Medicare and Medicaid. 10% of the people are saying that Medicare, they're waiting for Medicare to start before, because they have a serious disease but can't afford to pay for it right now. That's a huge issue. Next slide, please. We also found that, very interestingly, which we didn't know when we conducted the first survey, was that within the near abroad, and I'm going to define near abroad as Panama to Canada, 40 to 60%, depending upon the country, return to the US to get their medical benefits, even though they're living overseas. And the reason they're doing this is the fact that they can't afford the local coverage, because you've already paid for the hospital insurance to Part A while you've been working. And that's the really expensive part to be able to deal with. We also know that 15% of the people said, look, I'm healthy now, but when I get sick, I'm going back. This is from the seniors I'm talking about. And over 90% in all the countries, I mean, it varied between 88 and 92, right? Turned around and said, if Medicare were available locally and I could use it in my local hospital, I will not return to the United States. I'd rather have my care locally. It's more convenient. Of those who did say the 10% who would return, over 80% said it was because they wanted to be with their families. And they had families living back in the US, and that's why they were going back we would go back to the US even if this were available overseas. And then we said 18% of the seniors said they knew between 1 to 3 people who would move overseas, but don't today because of the increase, because of the issues of how to get proper medical benefits locally. And this is an astounding statistic if you think about it. You know, when you asked for who had more, these numbers grow a little bit more. But if you want to look at the numbers that are sort of really, you can point to and say, this is a number that when they go to score and look at making this work, is going to be able to save enough money? This is what they look at and say, where can we know that for sure that we're going to be able to save a little bit more money? Could we have the next slide? So what we're really trying to do is find a way to save the trust fund money, because this is going to become a major issue for the government, especially as you reach 2 more years from now or 3 years from now, when the trust funds become insolvent. And then the question is, how do you run something like this project? And so that really got started the issue of a pilot. And the next slide, please. Anyhow, on this slide, this is just for people to sort of take a look at. I'm not going to walk you through this. This is a little bit more about a slide just to give you an idea of what comparable costs are in the US for sort of standard procedures versus what you have in the United States. And you can see if you look at Israel versus Korea and the United States, you get some idea of where you get some pretty good savings. The Alzheimer's disease is an annual number, by the way. The next slide, please. And so, you know, if you assumed you had 15,000 patients per country, because remember, if you go back to our pilot of 150,000 and you said, look, you wanted to do 10 countries, right? What's the prevalence and what would be the cost savings? And just to give an idea of what these, 4 items would yield in terms of savings. Next slide, please. And the same thing here for Israel. Next slide, please. So we had language, as I mentioned, in FY21. We had language in FY22 that President Biden signed, which was much more expansive. We have a very good relationship with the Center for Medicare and Medicaid Innovation. We're working with the House, the Senate, the White House, HHS, trying to move this pilot forward. Everybody understands that this will save the government money. Everybody understands that this is an important pilot. We're now working on getting higher prioritization for this pilot as opposed to other pilots that the administration might want to do. And here is really where we need your help. And Heather, maybe I can turn this over to you at this point.
Sure. Yeah. So, we, as Philip has already explained, the studies that we've done and the projected savings. So I'm going to skip this next slide and basically the kind of pilot program that is being discussed with CMS and CMMI is to put together some sort of Medicare Advantage plan that would allow for the pilot to be run in a series of countries. Hopefully there would be countries in all three of DA's regions, both in the Americas, in EMEA, and in Asia Pacific. And that would allow for participants to enroll in those in that pilot in those three regions, and to get results, data results that will bear out the cost savings and the effectiveness of the pilot over a period of time. So far, CMMI has not yet put forward a program and a plan, and so that's where we are. And so what we would like very much from people who are here now to help us by reaching out to their members of Congress and their senators to help us push the administration, to push CMS, CMMI, and the White House and HHS to move forward with getting this pilot plan, this pilot program off the ground. So basically, to repeat, there was this authorizing language in the appropriations bill in fiscal year 2022, and it has language in that bill that says that they're going to review the status of it in 2024. But so far, nothing yet has been done. So there's no program that has yet been put in place, despite our best efforts, Philip's and mine, best efforts. So we are doggedly pursuing the administration and trying to get them to move the pilot program forward. But the more that they hear from constituents just how important it is that this pilot program move forward, the more seriously it will be taken. So we would like to ask everyone on this call to take the time to send a letter to both your two senators and to your representative. And we have a form letter. Emily, can you put up that letter? And we'll make this letter available to you, and it'll be a Google Doc, and you can adapt it, with your own information, send it to your own member of Congress and your own senators. And if you wouldn't mind, please drop a line to the Medicare Portability Task Force telling us who you are and who your member of Congress and senators are, so that we can do the follow-up to let them know that we know that they have heard from their constituents, and we want to follow up with them make sure that they are doing the work and following up with Health and Human Services, with the Centers for Medicare, and with the Centers for Medicare and Medicaid Innovation, and even with the White House, to make sure that everyone is putting pressure where pressure is needed to move this pilot program forward. So that's our ask from all of you for taking the time to spend the time with us today. So after this call, we'll make this available to you. We'll send you a link to the Google Doc. And like I said, we'll ask you to please send us a note afterwards telling us who you sent it to as well, so that we can do the follow-up.
I just think,
go
Heather,
ahead,
because
Philip.
I'm watching some of the questions here.
Okay, good.
One of the questions is, why do we use Medicare Advantage? And the answer is because that's what CMMI told us that they need to use.
Yeah, not because we wanted to. Okay, you know, and
this is the directive that we have gotten from CMMI, and partly the reason is the fact that Medicare medicine is delivered locally, and Medicare Advantage is set up so that they can ideally provide increased services, and that will reduce the overall costs. And because they're using single premiums to do this, you're able to sit there and provide more benefits. If you used fee for services, and I don't mean to go into this, but because I've had seen 4 questions that have come up, the reason that you do it is CMMI told us to do it this way. If you want to know a little bit deeper, it's because if, for instance, you were in Korea and you wanted to get treated with acupuncture, and acupuncture that's how they treat disease locally, and it's not covered by Medicare fee for services, the schedules, it would be considered an additional cost, and hence you would have all sorts of problems in how you solve for the model and deliver the care locally when people are local. So they've come back and said, this is how you do it.
Right. In other words, yeah, I mean, in other words, what Philip is trying to say is that in order to give coverage for all the different variations of the kinds of services that would be available worldwide in these different kinds of environments, that would be beyond what is available under standard Medicare, it would have to be a series of private or one global insurance plan that covers it under a Medicare Advantage insurance plan.
Yeah. The other thing,
and that's what we've been told. Unfortunately, fortunately or unfortunately, I don't. Well, let's sort of we'll leave the opinions aside. But we did ask them about alternatives to Medicare Advantage, and we've been told expressly that that's what they're willing to consider.
The other thing that people have asked as I've been watching the chat is,
Philip, I'm gonna stop you though, because we want to go through questions. We've moderated questions, so we'll take the questions with the moderator. Okay.
Yes, absolutely.
Okay, and thank you so much, both of you, Philippe and Heather, going through the results of the survey, telling us about the pilot and our need to support it, and all the hard work you're doing on the Medical Portability Task Force. Thank you so much. It was very informative, I'm sure, for all of us as the participants. What I'm going to do now is go through a series of resources that Marnie from the Disability Caucus and myself have put together for you, and these slides will be shared for you. You'll get a copy of these, so you don't need to write down all the links, because basically it's a PowerPoint of all the links that you might be interested in. Okay, so I'm going to kind of go through that. It'll take about maybe 5 to 6 minutes, and then we'll go into the questions. Next slide, please. Thanks. So these are the caucus websites, which you can access, and also an interesting article by Philippe that we've added there from the Medical Portability Task Force. Okay, next slide, please. You can find your local office in the US at the first web link. You should know these aren't really official offices, but people there are trained to assist you. There's also general information on Social Security, and by country, the last link on this slide for living abroad. Next slide, please. The links to a screening tool regarding collecting Social Security benefits while overseas is the first link. The site discusses exceptions, in other words, collecting disability benefits. And this also, the next link has information on countries where you can collect and receive benefits. Next slide, please. And here's Medicare benefits. The site includes the basic information you want about Medicare, which we've discussed today, and also includes information in Spanish. Next slide, please. And things like, and I won't go through them all, but these are the things that they can actually answer your questions about. Okay, next slide. The Medicare site is located at the first link, Centers for Medicare and Medicaid Services, the second link, and submitting A and B appeals, which Tony talked about, the last two links on this slide. Thank you. Next slide. Okay, technical health and human services information for state and provider handling of Medicare on these three specific links. Next slide, please. Medigap, Medicare supplement health insurance. We have provided the links there, and then also children's insurance program is the last link there. Okay, we're going to take questions, but before I do, I just want to have a reminder to you all that the purpose of this meeting has been really to provide key information about Medicare and about the decisions you will need to make about managing your benefits. We're really not qualified to provide specific answers to questions about individual situations. However, we want to help you find the people who can, and we would recommend you connect with official channels rather than taking advice elsewhere. As you learned from today, the system is complicated, changes regularly, and is of course not the same for Americans living abroad. And we've gone through our list. We'll post a link to connect you to all this information. And as I say, all of the PowerPoints you'll be receiving also today. So what's going to happen now is we're going to rotate questions from emails in the chat. And Marnie, over to you.
Yes. Great, thanks. Thanks so much, Betsy. Now, we've had a lot of questions and, we did have some prepared, but I want to just start with one very general question that I think was reflected in a lot of the comments and questions. And that is, in essence, why can't Joe Biden just fix this discrimination? In other words, why do we have to go through all of the pilot? People are seeing it as discrimination, and it's just why are we not following some route of just directly asking Joe Biden and our Congress people to change the law? And I think I'll ask Philip and I'll ask maybe all of you want to comment on that, but maybe Heather, you have a thought?
Okay, well,
it's a hard one.
It's a hard one, but basically the short answer is that Medicare, as it was prepared, okay, and conceived, was designed to cover Americans in America. And it was not designed and conceived to give services to Americans outside of Okay, that was the way it was designed. What we are asking them to do now is to reconceive their process and to provide services in a completely different way. And that would be to and this is a unique thing. I mean, no other country that I know of really provides expansive, comprehensive healthcare for their citizens who have, you know, healthcare, state healthcare outside of their country. You have to buy it for when you travel or for when you're staying outside of that country. So what we're asking for is a unique situation, but here there's a cost savings and there's a driving force behind it. And because of the fact that this would be available to Americans who have participated in Medicare in the sense that they have contributed to the Medicare fund by having participated in Part A through their employment, and therefore have certain entitlement to participate. Not everyone who lives overseas has worked for an American organization or as an independent contractor and is paid into Part A during their employment, and therefore not everyone really falls into this rubric. But for Americans who do live overseas, who have paid into Part A, and who are living in the United States and do want to move overseas and have paid into Part A, there is this opportunity where their interests and the interests of the United States in saving money align. And that's where it comes together. It's really not something where Joe Biden can say, oh, this is some sort of interest of equity or something like that, because
Right.
they don't
not
have
any control, and they don't have control over the medical services abroad either, which introduces a whole
there isn't
whole other range of issues.
The medical services that are available overseas are truly distinct and different, and here we're asking for them to be treated as if they are part of a health insurance plan that is now going to be part of coverage under the US Medicare. Yes, it's going to be different.
Betsy,
I'd like,
you want to jump in?
yeah, I'd like to comment on that, on whether or not this is discrimination. It's actually not discrimination. You pay into Medicare Part A while you're working, and once you retire, once you stop working, you don't have to pay into it anymore. That Medicare Part A is available if you come back to the United States. As far as Part B is concerned, you don't actually start paying that until after you retire. So it's not like you've paid into Part B and then can't use it. You haven't paid it. And if you want to be able to come back to the United States, or if you anticipate that you might need to come back to the United States, you have the option of paying the Part B premium, no problem. So in that sense, it's not like you've spent this ton of money over your working life and now you can't access the benefit. That's really not the case.
Great.
Although there are, I mean,
Yeah.
just to further
Oh,
push the point, there are people who live overseas who do pay the Part B premium and cannot use the benefit. Okay. And the reason that they continue to pay that Part B benefit is because they believe that they will go back to the United States at some point, and they wish to preserve that option. Okay. But during that time that they're overseas, they cannot use the benefit because it's not available to them. And I think that during that time, they feel a certain frustration because they need to have some other health insurance option. Or they need to travel back to the United States for healthcare.
Yeah.
If it's possible.
I-
And as our survey found, many of them do if they live in the near abroad. So I think yes,
If,
Philip.
if I may just add, because of President Biden's FY22 language that he signed, he actually could get the pilot started overnight because CMMI actually has that power because of what's in there. So there is, and this is why we've been working hard with the White House, because this is part of reprioritizing what an understaffed CMMI can do. And part of why we really need your help for the Congress, and why Candace and Heather have been really helpful, and the whole team has been helpful with the White House, and we need to go back to them. But it's important to know that they have all the languages that they need in order to be able to start this. This is a part of the prioritization issue. And that's why it's important for everybody to please get their letters in, because it helps push this up the prioritization tree.
Okay, thanks very much, Philippe. And Heather, there's a question for Tony here. In your experience, what's the most common mistake people make when managing Medicare benefits?
Boy, that's a broad question. I think and I don't have a specific answer to that, but overall, in my experience, the difficulty most people have with Medicare is not understanding which part covers what, and how to effectively get the benefits that they've paid for because of this misunderstanding. Another big problem is that all of you will have seen either online, in print, on television, the deluge of advertising from the insurance industry about Medicare Advantage. Medicare Advantage, first of all, is a misnomer. It's not really Medicare, it's private insurance. And many people see the name Medicare in the title and assume that it's Medicare. And that is a completely erroneous assumption. You know, you call your doctor and they ask you what your insurance is. You say, I have Medicare, and you get there for the appointment. And it turns out that doctor is not in the particular Medicare Advantage network. And, oops, I waited 4 months to see this doctor and, I can't see the doctor. So in my experience, and in the experience of doctors that I've spoken to in the course of doing my Medicare Reporter newsletter, that is a huge issue, is the misunderstanding about what Medicare Advantage is. In my personal opinion, they ought to change the name.
Right. There's somebody that does ask a question here. It's an interesting question. I live in Mexico, where many hospitals and doctors advertise that they accept Medicare Gap and Advantage programs. Isn't this fraud? How are they doing this?
Okay, Medigap, which is the supplemental insurance product, does, well, some of the plans have a provision for treating emergencies outside the country. And I can't speak specifically to the specific hospital, but if they submit the claim as an emergency claim, then they do take it. Overall, Medicare is not available outside the United States, except under very narrow, very well-defined circumstances. And if you live in Mexico or in Canada and the hospital says they accept, a Medigap plan, in all likelihood, they are coding it as an emergency visit.
Okay.
They're coding it as an emergency visit for a tourist.
Right.
Right.
Okay.
Okay, so here's another question. Philly referred to this a little bit, with the aging population, the whole care economy being a mess, the budget being the budget. What do you think is the question? Is it going to fail? Is the whole system going to go away with or without the Republicans' help?
The
Or
system
could
will,
it, I guess.
I'll take that. The system will not go away. Just like the system will not go away when Social Security reaches insolvency. There will be a reduction in what the payment for benefits are. And that will then depend whether they increase the size of the deficit to be able to cover whatever remains, or they will simply say, you know, instead of covering everybody at Y, we're only going to cover them at Z. But it's not going away. No one's going to find themselves without any insurance. No hospital will turn people away.
Anyway,
That's sort of my short answer of this.
Okay, that's good news. Okay, Betsy.
Okay. I have another question for Tony. And it's about if I stop paying for Medicare, but then decide to move back to the US or perhaps lose benefits in the country where I currently live, can I immediately start back up again?
yes, you can reapply for Medicare Part B. None of this affects Medicare Part A. Once you've applied for Medicare, Part A is yours. You can live anywhere. You just can't use it everywhere. As far as Part B is concerned, if you were getting Part B while you were in the United States, you then move out of the country for a period of time, you stop paying your Part B premium, and then you want to go back to the United States for whatever reason, yes, you can restart your Part B benefits. However, for every year that you were eligible for Part B and did not pay the premium, you will pay a penalty. So for example, if I had Part B in the United States, I left the country and lived in France for 5 years and didn't pay my Part B premium because I had this great insurance in France, and I go back to the United States, I want to start my Part B again, I will be assessed a penalty of 10% per year for every year that I was eligible but did not pay for it, which is 5 years. That's a hefty penalty, and it's a permanent penalty. So as Heather mentioned, that's one of the reasons some of us elect to continue our Part B premiums while living out of the country, because personally, I'm 70 years old. I don't think I'm going to move back to the United States, but I didn't think I'd be living in France either. So who knows?
Right.
Great,
Okay.
thanks.
Marnie, can I ask a related question about to Tony about Part D? Because somebody asked here, does one need a U.S. residence, real or nominal, to buy Part D? Is it up to the individual insurance company, or do they have to sell it regardless?
And they also asked that question on Medigap.
Yeah.
Right.
Okay. First of all, yes, you have to be in the United States in order to buy those plans. As far as Medigap is concerned, the reimbursement with Medigap is all based on what Medicare is going to pay. So if you can't use Medicare, Medigap isn't going to do you a heck of a lot of good. The other thing about Medigap, and again, this speaks to one of the issues with leaving this stuff to the private insurance industry, is unless you sign up for Medigap during your initial enrollment period for Medicare, which is that 3 months before you turn 65 until 3 months after, you will be subject to medical underwriting. That means, so in your initial enrollment period, no matter how sick you are, you will be able to buy a Medigap policy without any kind of penalty or any medical questions or anything like that. If you sign up after that period, the insurance company is entitled to reject you for your medical history, charge you a higher premium, unless you live in one of the 4 states that are called must-issue states. So there is no short answer, but no, you can't use any Medicare product, either A, B, D, or Medicare Advantage outside the country, and you can't sign up for it, if you live outside the country. There was another question sort of related to that about accessing the Social Security website while you're outside of the country, that you can't do it. Well, yes, technically it's blocked. Most people use a VPN, no problem.
Right. That's true. So there's a question, I think you've touched on it, but some people have had most of their income or much of their income made outside of the US. And so what are the implications for them? How can they, or how can they, and to what degree can they get themselves into the whole Medicare system?
They can apply.
There's
if you haven't paid enough to qualify for premium-free Part A, you can apply, and depending on your income, they will charge you a premium. And the same thing with Part B. I can tell you, and this is probably going to surprise a lot of people, but the standard Medicare Part B premium, $164.90 in 2023, is a bargain considering what it covers. Try to buy that kind of insurance on the open market, and you will, if you can get it, you're talking about thousands of dollars in premiums. Medicare is a bargain. It's a bargain at twice the price. I realize it's expensive for some people and it's a hardship. I understand all that, but in the insurance world, in the health insurance world, it's a bargain.
Great. Thank you. Betsy? Oops.
Sorry, I was muted. I'm just looking over the questions that came in the chat box.
Okay. Okay. So what, maybe maybe you could, there was one question we haven't asked, and that was, are we as Democrats Abroad alone in this? Are there other organizations of citizens abroad, or of, I don't know, Medicare freaks that are involved in moving this forward?
Sure. Thanks, Marnie, for the question. In fact, Americans for Tax Reform has been helpful in promoting our survey. We've had some interesting discussions with the Catholic Church. They're interested in seeing this be successful because they have retiring priests and nuns who are interested in retiring outside of the United States, particularly in Rome, in Vatican City, or in Israel, for instance. I'm in Israel, and those are two of their favorite places to retire, but they would like to take their Medicare benefits with them. And the Congressional Hispanic Caucus has been very, very interested in supporting this. Congressman Esplat, I don't know if anyone is here on the call, is from his district, but he's been very, very supportive. And if anyone is familiar with Nefesh B'Nefesh in Israel, they've also been very, very supportive of this program, because they think that it will help encourage people to move to Israel. So
Right.
Those are a few of the international organizations that have been quite helpful in this project.
All right. Is it my imagination, or have we reached time? I can't, I have so much light in here. In that case, I really, sorry about that. First of all, again, there is a lot of information that will be coming to everyone. I want to thank all the participants, all of the people in the caucuses, the caucus steering committees and members of the caucuses, and all of the people that asked so many great questions. And what we'll do is, number one, we'll look at the questions again and see if there's anything else we want to add to the information that we distribute. And I apologize if we didn't get to your question, but then we will also encourage anybody that's been participating to join Democrats Abroad if you haven't already, and to join one of the three caucuses represented here, the Senior Caucus, the Medicare Portability Task Force, and the Disability Caucus. Of course, anything you can do to make donations to Democrats Abroad, it also helps us get some of this work done, because it's not free, and just like insurance. And so finally, do get yourself registered. I'll reinforce the whole notion that this is a local issue. It's not necessarily a federal issue in many cases. Your insurance is regulated by the state in which you are voting or come from or move to. So at any rate, thank you all so much for joining us. And I'm sure we're going to be back with more information. I know there's going to be a conversation about WEP, which I'm not even going to start to talk about. And we're going to be having conversations on the care economy and what it means to all of our various members that are abroad and or in the United States, back and forth. So thank you, and we will see everyone soon. Take care. Bye.
Thank you very much. Thanks, Marnie. Thanks, Betsy. Thanks, Tony.
Thank
You're
you
welcome.
all.
Thank
everybody.
you.